Go.
Hey, Kevin from Emergency Medicine. I'm going to talk about back valve mask ventilation, and mainly in the setting of the, we'll call it the rescue, like a unsuccessful first attempt intubation, and we're going to bag the patient up. Okay, so common things that I see: not using end-tidal CO2, not using quantitative end-tidal CO2. Absolutely not okay not to use this, okay? End-tidal CO2 gives us an idea on perfusion status, ventilation, and airway patency. You have got to have this on here, okay? And you're gonna have your mask, you're gonna have your nasal airway and your oral airway. All right, so what I'll see a lot of times is the blade will come out of the mouth, okay, and here comes the therapist, okay, and they've got their setup, and then they're doing this, okay, and there's no adjuncts, and here's the problem with that is, so we've given this patient a paralytic, everything's relaxed, number one airway obstruction is the tongue. And when we get up here and overpressurize the airway, all you're doing is just driving their tongue down in their airway. I see video on a regular basis, people that are bagged without adjuncts. You're not getting rise and fall of their chest. Your end-tidal CO2 will be like 10, 8, 9, and we're not doing it effectively. So before this goes in, okay, before you do this, you need to do this. And I won't bother with telling you how to put an oral airway in, but oral airway at a minimum, if you're having problems bagging the patient, you're gonna add an NPA. You put the NPA in too. Then, I don't care who does it, but somebody needs to do mask seal, not one-handed, okay? You learn from anesthesia this whole one person bagging thing, and that's all great, but here's the thing: in an elective environment, that tends to work really well. Here's what works every time: is two-handed mask seal with your thumbs pointed down. These 8 fingers are lifting the jaw, you're pushing the mask into the face like so, and then you have another person that's squeezing the bag. I don't care how this gets done, but I'll just tell you, this right here, there's times we'll get away with it, and there's a lot of times that I'll see this being done, and we'll have a couple of physicians over here, and everybody's watching the saturations, and they're not improving, and people are looking puzzled. And hey, maybe if you put in an adjunct and do 2-person mask seal or 2-person bagging, thumbs down mask seal, you'll be more successful. So, in closing, one other little thing. Prongs. Okay, if we're in this situation right here, these things got to stay on. It's high, 40 liters a minute. Just anything, this is an absolute lifesaver. So, in summary, in closing, these 3 items right here, the mask, the oral airway, and the nasal airway, I want you to think about this as like a seat belt. You know, this and the prongs are like the seat belt in your car. They're there for your safety. The first thing that you're gonna reach for when you have an unsuccessful intubation attempt is this mask and an oral airway and a nasal airway. These things need to be close at hand. Not only you, the therapist, need to know where they are, but everybody needs to know where these are, because when the blade clears the mouth, the first thing that needs to go in is this, maybe this, then this, two-handed, with end-tidal CO2, et cetera, et cetera. Thanks for your time.